Good afternoon, everyone. Hope you're okay. Hope you can hear me. I'm Josh. Mondays and Thursdays. I still haven't changed that thing. Still says Monday and Friday, sorry. We tune in for a chat about whatever is topical in MSK practice, and obviously we prioritise what's important. Today's topic is a very important one. I'm really looking forward to speaking to Kate Brown and Laura Hemmings about that. Now, a couple of minutes late is because the technology has not been behaving itself very well for us in the lead into this show, and so if you can hear me in the chat, if you're tuning in live, have to go and have a check and make sure that's all behaving itself. If for some reason the audio or the video it's not streaming well, then I'll get Kate and Laura onto something. We'll record something and get it out to you, because this topic definitely needs covering, and that's just some reason the tech gremlins are after us today. For those of you that have been in touch in support and suggesting episodes, it's partly from that we've really wanted to put this together with these, because this subject matter is really important and clearly really important to you as well. So really looking forward to getting stuck into it and how it does work. And if not, I will refresh it, stick with us, and we'll be with you shortly. I'll be joined by Laura and Kate. Can you hear me?
Yes, just about. It's in and out still, but yeah, great.
Yeah, I think there's a big delay, but yes, I can.
Yep, I'm here. Yep, can hear you fine.
Good. We've got a bit of a delay. Firstly, then, could you start off by just telling me a little bit about who you are and what you do?
Yep, shall I go first, Kate? I am currently working as an assistant professor at the University of Birmingham, where I lecture about mental health and try and kind of weave mental health through the curricula in the different topics. And previously worked for about 10 years as a specialist in mental health field, and also studying my PhD in the role, benefit and barriers to physiotherapy and mental health. So really interested in the discussions that come out following this podcast as well.
Fantastic. No, thank you so much for joining, Kate. And it does seem like it's maybe my audio that's the problem, and sorry about that for those letting me. Thank you, Talita, for letting me know that, but I'll do what I can. I'll try and change some stuff over. But in the meantime, Kate, if you can let us know, who are you, where do you come from?
Yep, so I'm a physiotherapist working in mental health, and I've been in mental health for about 8 years as part of a really fab mental health team within inpatient acute services, and my clinical speciality is within eating disorders currently.
Oh, fantastic. Well, thank you both for joining and for tolerating what seems to be bad this afternoon. One of the questions that I really feel like I wanted to open with, and the title, a bit of an unusual one, I guess, to this episode, is that when thinking about mental health and physiotherapy, there are some people that really struggle to understand and place that. And one of the reasons for it is because it really should be considered across the breadth of the profession, as well as the breadth of healthcare. One of the challenges there then is that because it ends up being a risk of being almost too vague, that people struggle to understand its practical application. If I can, and I'll go to you, Laura, first, could I just invite your thoughts on its place, its interaction, its relationship, both historically and where you feel it should be now?
Yeah, so I think historically we've tended to kind of silo physical and mental health care across healthcare professionals. And I think it's much more recognised now that the two need to be integrated, and that mind-body connection is much more recognised. And I think we're doing a really good job with that in physio, kind of considering the biopsychosocial model, really pushing for that holistic model of care. But I still think we've probably got quite a long way to go. And I still think that a lot of the time potentially, and whether that's a lack of awareness, whether that's a lack of education, or whether that's more a kind of clinical setup that makes it difficult to address the mental health in our physiotherapeutic consultations, it's not always recognised, and it might not be kind of that physios have the confidence to address the mental health side of things. I think in an ideal world, we'd recognise our role in the treatment of physical and mental health and try and integrate those and bring those together.
Absolutely. And do you feel that are we trending positive for it, physiotherapists and the awareness of it moving for the better, or is it something that's in a steady state in your opinion?
I think it's probably improving. I think the recognition, at least, and the kind of, we're asking the right questions now. So we're finding out whether our patients have got that kind of psychosocial side to their presentation. I think potentially the area where we need to now work on is, what do we do with that information? So where do we go with that? Do we just refer them on to CBT, or do we recognise that actually our role in things like exercise and other potential interventions that we can offer could really support their recovery from a physical and mental health side?
Brilliant, thank you. And Kate, to bring you in on the same sort of general question or theme, especially as someone that's expertise is then also in an area where many people wouldn't consider physiotherapy to be top of the list or near the top of the list for professionals that would be required in something like eating disorders. So I just wondered if you could just reflect on the role as you see it for physiotherapy in mental health.
Yeah, I think I echo what Laura said actually about the huge value of it. The recognition is much greater. I guess if I think specifically within eating disorders, there's 16 of us in the UK that work in eating disorders, and that's considerably more than there ever has been. And I think it links in with mental health as a whole, is that recognition is there, but where do we sit in terms of those commissioning documents and the funding and nice guidance? And I think that's a big push for us at the moment, certainly within Chartered Physios in Mental Health as a specialist interest group, the CPMH. We're really kind of championing that aspect as well. And I think, sorry, go on.
No, that was me just agreeing along, but I've got a delay. So sorry, you carry on, Kate. I didn't mean to interrupt.
No, and I think I'm just echoing everything that Laura said. Basically, I think our role is hugely about health promotion, and health promotion must include mental health as well. If I think specifically to my experience working in an inpatient acute units across all age ranges, from children and adolescent up into older adults, where we may have referrals across all different ranges from a physiotherapy perspective: neurological, orthopedic, rheumatology, MSK, your older adults, your deconditioning, your falls. You do have to be, like you said at the very start, a real generalist within a really specialist area. And that's really difficult because it's spreading yourself, isn't it? But I think it's so important to be advocating the fact that although patients are primarily in hospital for their mental health conditions, their physical health is just as equally as important, and sometimes can hugely impact on their mental health condition and vice versa. So we need to be there positioned to be supporting both as a whole.
Most people, especially I would always compliment our audience in being thoughtful on this, they're a long way from being mind-body dualists, right? They've grown out of that. We are not isolating and separating that off in any way, which is of course promising. But where it is difficult is when the infrastructure that might exist in the health systems, or people feel like they might be over encroaching on the scope of other professions or professionals. It starts to become difficult, because whilst they want to be truly holistic, they might be struggling to understand their role within that. And one of the big risks, of course, is if they take on too much of that, in a way over-empathize in many ways, they start to burn themselves out if they are overreaching. So it's a funny one with regards to the practitioners as well, of course. It's a fine line there. Can I get you both to reflect on where the evidence is strongest in this space? You feel, therefore, the primary indications for us, what's the thin end of the wedge for us to make sure we then improve both awareness as well as then where we could prioritize intervention? I'll start with you again, Laura, if you would.
Okay, so I think the evidence base is very clearly weighted towards exercise. So Brendan Stubbs has done a brilliant job of kind of exploring this area, and his team have really evidenced the role of exercise to both as a treatment and a preventative measure for mental health and mental illness. And I think as the kind of, I guess it's a cornerstone of our treatment and our kind of profession, really, isn't it? Exercise. We are potentially kind of seen as experts in exercise prescription. And I'll let Kate talk about kind of where those barriers may be and where those boundaries may be more so. But really using that evidence to kind of think, well, how can I have that discussion with my patient? So if they're coming into a physiotherapy consultation and they've got a chronic pain condition, because we know the high prevalence of chronic pain and depression and anxiety symptoms, for example, how can I talk to them, therefore, about the benefit of exercise as well? So not overreaching, not kind of counselling them around their mental illness, but acknowledging that mental illness and validating that, and then saying, actually, exercise or physical activity, let's move away from just the phrase exercise. Physical activity can really help support your mental health as well as your physical health. So it will go hand in hand and maybe address your pain and your mood, and just have those conversations, educate patients in that respect. Because I think, as I say, there's research for other areas elsewhere, especially kind of on an international scale, like the body sensory techniques and more psychosomatic side of things. But I think here in the UK, we're much more kind of inclined towards that evidence base for exercise. So I would definitely push that route and that conversation with patients.
Fantastic. Can I, sorry again about the delay, but Kate, if you're in on that, especially if you could as well on any of it, evidence support some of the more specific areas.
Yep. I lost you at the end there, Laura, so apologies if I repeat anything you say. I think also, just to note, there's quite a big drive at the moment for the evidence around physical activity within suicide prevention and reducing violence and aggression within inpatient units. I've been involved in discussions recently about non-contact boxing and actually where that place is in terms of that fine barrier when we're thinking about violence and aggression, but actually the therapeutic benefit that can come from that. And there's big pieces of research coming out now around a really valid place of physical activity that is supervised and appropriate and guided within an inpatient unit. And I think it's important not to miss off kind of our older adults and our dementia care, for example. And actually, from a mobility functional perspective, the evidence is hugely there to support physiotherapy within older adults and falls prevention and reducing falls related injury as well. If we think about from an eating disorder perspective, Laura kind of touched on, actually, there are some clinical settings where there is huge evidence to support the importance of addressing exercise in a healthy way. And that's one big part that we're playing as physios within eating disorders at the moment, is that we know that as part of that illness, exercise can become a real maintaining factor and actually become quite dysfunctional. So physiotherapy, absolutely, as exercise specialists, we come in and we support that re-education of how to find that healthy balance with exercise as an individual or patient is recovering from their eating disorder, so that there is a reduced risk of relapse rate and chronicity of the illness. And exercise education plays a huge part in that. And that's where physio comes in.
Yeah, a really good example, and one where admittedly there's areas of this discussion where I'm certainly weaker and very much a student, and then there are other areas where I'm a bit stronger, purely because those that have come before you teaching me about this stuff, particularly when it came to things like understanding RED-S, understanding metabolic disorders, understanding lookouts, especially for young athletic women coming through and disrupting their physio significantly with a combination of eating disorders and compulsive exercise. That it brings me on to for want of a better term, so things that might be then, because a lot of our audience job in MSK clinicians specialising in pain and injury, those sorts of making sure we recognise and then make that decision as to whether to make a sensible first intervention or to refer, signpost, but the awareness of it for therapists is super important. And so I just wondered if you guys had any top tips for what the classic lookouts are. You know, are there ways in which you feel people could just be recognising and keeping their spidey senses readied for when that might happen?
I'd say the main thing there is really listening to our patients. I think it really comes back to that, really understanding them, asking them those open-ended questions around how their pain makes them feel, and then understanding kind of when that started making them feel that way, which one might have come first, how do they both impact each other, to then recognize, okay, this is somebody that might need something alongside their physio. I'm not saying that, I mean, there are times maybe where a patient, their priority might not be physio, and it might be that they need some CBT or some psychological input prior to that physio. But I would normally suggest that actually, if they're at that point of coming to see you as a physiotherapist and they've come to an appointment, then it is one of their priorities. And it might be something that, instead of saying, no, you've got something psychological going on, I'm going to refer you elsewhere, it's integrating that and working alongside those CBT specialists, or bringing in other elements, and working with our MDT colleagues to make sure that we're giving them physio and other elements. But truly listening, truly understanding, I think is the central component, because there's so many different presentations. A patient with depressive symptoms can present so differently from another. So it's very difficult to say there's something exactly to look out for, other than really understanding and building that rapport.
Fantastic, yeah, and same again, Kate. If you anything to add to that?
Yeah, I kind of really important skills that we all have as physios. It's just kind of widening it, isn't it, into kind of a holistic approach, to be thinking about, are there barriers to engagement in activity? I think about it from an eating disorder perspective as well, thinking, are there any kind of warning signs that a patient presents possibly with a musculoskeletal condition that's come from overuse from dysfunctional exercise? Yet actually that's really difficult for an individual potentially to be disclosing information about an eating disorder. They may not be at a stage where they're able to do that. Yet what you're kind of marrying up is, how well are they engaging in my treatment? Are they actually able to manage the advice and guidance that I'm giving them, in terms of, even for example, in terms of rest and recovery of an MSK injury, for example, but what you're expecting to see as part of that recovery process doesn't happen? That kind of would make me wonder, actually, how challenging is this relationship with exercise that this individual really has, and can I be supporting them from that perspective too? We're obviously not going to be spending a kind of an outpatient appointment talking about a whole education session around dysfunctional exercise and how it links with their eating disorder, but perhaps kind of just flagging with them about, well, actually I'm a little bit unclear as to why I'm not seeing the improvements that I would be expecting to see based on the advice and guidance that I've been giving to you. Is there anything else that we can be thinking about supporting you with, or signposting to? And then that kind of links in with other additional support that could be available.
No, that's fantastic, and that's where sometimes it can be tricky to really comprehend until you just give that a whirl. You know, recognizing that level of what it is you might use as a light touch, or even more meaningful intervention, as long as you've got the skill set and competence, and knowing where that is appropriately guidance and signposting, where you make sure you don't end up being out of your depth and feeling uncomfortable. You know, it's a fine line. One of the examples I feel like I wanted to share with you, especially locally, we've had a number of charities sprung up and doing great work in improving community talking therapies, demedical mental health care where necessary, including the reason I mention locally is because there's a particularly northern charity called Andy's Man Club. I don't know if you're aware of, but it's trying to get talking therapies amongst groups of men every Monday night. The reason I found that interesting is because they've never really considered physiotherapy as being an interesting partnership. Whereas when you witness any of these conversations, I've been there as a punter myself, but also then taking patients there. And they don't necessarily realise just how much some of the things that they're then trying to encourage, it's not just the talking, channeling someone to get themselves functionally, may that to get into the gym or to exert themselves, or to encourage them to active play even, and just re-engaging. They don't realise necessarily how the guidance of an appropriately thoughtful physio or physio service would be a brilliant conduit to that. because there were so many that have made massive strides from talking about it. But now what? And what could I do for myself as I try and re-emerge from this? And I'm no longer keeping it to myself, but is that it? We just keep talking about it. And so it's a really interesting opportunity, I think, for physios of all types and stripes to just try to recognize that getting people to scale their functional ability as a core skill, and reassuring them where appropriate that it's safe to do so, can be a massive superpower in this area. And as long as we know then what is available locally, it can make a massive difference. Admittedly, when it comes to some of the more specialist areas, or when things get more serious and there's more overt, say, psychopathology, that is something that people do get, dare I say, a bit nervous about, or sometimes I've been told, even by GPs that we've worked with before, sometimes a bit trigger happy on referral. So could you give us some top tips on some of the sort of mental health first aid side, where someone might suggest, say, suicidal ideation, or show signs of being in quite significant distress, whereby it would be smart to aware of that urgently?
I think that's where your recognition and validation and acknowledgement comes in, of actually discussing with that individual that actually I can see that things are quite difficult for you at the moment. What support do you currently have? What support maybe can I offer you to signpost you to, so that there is that potential for that onward support.
Yeah, and to add to that, I guess, and I think I agree that sometimes those obvious kind of pathways are not always there. So when we ask those questions and we identify that maybe somebody is experiencing suicidal ideation, the pathway's not obviously clear, and especially for our kind of, potentially for our newer physios, it's knowing what to do with that information. And I think just making sure that you're making people aware of that. So if they are kind of immediately feeling like they are potentially kind of suicidal, it's the same way as we treat any other red flag, really. We would get them kind of seen. It might be like immediate referral, speak to their GP. That needs to be addressed there and then. But I think there needs to be more awareness of those pathways, and those integrated pathways need to be more easily accessible. And I think that will come as we develop this kind of more closer links between mental health services and physical health services, but it's potentially still a long way in the making.
Yeah, fantastic. No, that's great. Thank you. I've got a few comments from those that are tuning in live. Many thanks for those. Marie Donahue, is that how you spell it? No, probably not how you are pronouncing that. Sorry. It's like when guests will mention celebrities in their field that I don't know the name of, so apologies to Graham for this, but vanguard of research and impact of exercise in these areas. Is that a name you guys are familiar with?
Yeah.
It's just me then, sorry. There's a comment here. They may not recognise it as a problem at all, so even when asked directly and pointed in a direction, it can still be viewed as something completely irrelevant. Is that a classic sort of barrier? Have you got a favourite way of sort of making sure the penny drops?
I think it's repetitive. What I find is actually that individual might not be at that stage of being able to, in terms of their kind of motivation of change, their recognition of their difficulties that they're facing, that being the same at a point when that individual is able to then recognise it. So yeah.
Yeah, I think that's a really good point, isn't it? It's timing is everything on something like this, and as a therapist, you shouldn't burden yourself in thinking that the right phrase delivered at exactly this moment would work, and that to some degree you've got to recognise that it might be that it might be the next time of asking that this might land well, and not to burden yourself too much with that pressure. Here's an interesting one from Talita. Can I just throw in here that CBT is not always indicative for lots of reasons? Perhaps maybe you guys are only using it as an example, but I felt it important to point out. What your thoughts on that? I didn't necessarily hear you guys suggesting it is a catch-all, although that is a trend in some ways. You know, that there is a holy grail that is CBT. So just reflect on that if you would.
So I think I mentioned it when talking about exercise alongside other psychological interventions such as CBT. I probably refer to CBT because there is an interesting recent study, well, I say recent, 2018 by Matt Holgren, where they looked at exercise alongside internet-based CBT and the impact that exercise delivered kind of by a qualified professional can have for patients. So I think that's probably why CBT, but yeah, definitely just an example, and lots of other kind of pathways that you might go along, or other treatments that you might consider.
And I think if I could just chip in, sorry, that's just reiterates the fact that we work as an MDT, and that's where linking in with our clinical psychology colleagues is absolutely vital, because they're the specialist in terms of guiding and leading on the psychological interventions that individual may receive.
Yeah, that's very true, and understanding and helping to get better comprehension of each other's professions, guidance, scope, is only going to help in that direction. And working shoulder to shoulder, there's no way better than that, is there? Here's an interesting one. Thank you, Nicola, for the comment. She said, "How do you see the future of mental health services? How do we best share with students, new qualified practitioners, that mental health is an exciting and varied career option, because there's lots of stigma and fear around it?" Firstly, would you agree with Nicola's last assertion over it being stigma and fear? And then how would you overcome it, if you have any suggestions?
I think that, yeah, there is, I mean, the literature shows there's a lot of stigma and fear. We're actually doing a study at the moment, which I will shamelessly promote, our survey, where we're trying to understand that stigma and fear and what current practicing physiotherapists across all areas of physiotherapy think, and their experiences of working with patients with mental illness, so we can improve that confidence and try and overcome that stigma. But I think for students and newly qualified, it's understanding, it's weaving that into the education system, it's promoting that awareness, and wherever we can, giving that experience as well, because as Kate said, there's very few eating disorders physios, there's still very few mental health specialist physios as well. So trying to get those placement experiences out there if we can, and if we can't, well, can they go into kind of any area? We've just discussed that due to like level of comorbidities, any physio is likely to come across a patient with a mental illness, and reflect upon that experience of working with patients with mental illness outside of specialist settings as well, and use that as a learning environment too.
Yeah, absolutely. I think that's a great shout. And Graham's making a point here. It must be in the curriculum. He mentioned earlier as well a point that I didn't bring forward. Important to introduce to students this area of practice, both in practice and in uni. And that last point is crucial. Not just in theory, but then how does that apply in practice? I found it really interesting where sometimes, and we've had this on this show recently as well, is that undergraduate curricula, everyone wants their own favourite thing in there. But things like this need to be woven throughout. It's not a module, it's not a slideshow, it's not a placement, if you cross your fingers, that someone's thoughtful on this stuff. It's something that, much like my colleague Alistair Beverley, is the learning disability physio, and that he's long said that it's not that I'm trying to get a couple of slides into your curricula that a few people are paying attention to. It's more that then in case studies, these things are brought to bear as how it would intersect with clinical areas, so that people can realise that these things are sometimes separate when specialised, but rarely. It's mainly how these things will affect every last thing we do, from respiratory through to sports physio, and realising and bringing that to bear in case studies, both in practice and at uni. So again, I'm soapboxing a little bit there. Feel free to disagree in case you need to on that last point.
And what I'm seeing as well is a lot more requests from universities for us, certainly within our team and our colleagues, and I know it's the same nationally as well, of actually encouraging us to come in and talk about mental health physio and how that's applicable in different clinical settings. We've just had a really fab student on placement with us in our team who was able to even reflect themselves about, you know what, all of this that I've just learned is so applicable to my next placement and my next placement. And she was actually super motivated to be able to take that back to her university and share that with her peers. And I think that's a really valuable experience, because a lot of students that we have that come into our team even come in and they're really honest. Wasn't quite sure what to expect as part of this placement, but at the end of it, actually going away and thinking, no, it has such a valuable role that we can play, and the transition into other clinical settings as well is really important.
Superb. No, thank you so much for your time, both. I noticed we're out of time. I started it slightly late, so we're just going to wrap up. Many thanks to those that have contributed on the live show, but I am very aware, of course, that most of you tune in on your commutes or after the fact. So if you have missed the live stream, but you still have some comments and questions, please do put them in the chat or email info@physio-matters.com, and they will be forwarded and integrated into future content that we create. Also, for the two of you, if I can just invite you to point people in the direction of any of your work, but also any interactions that you're inviting from social media, etc. So firstly, you, Laura.
So I will kind of recommend, if you're interested in this area, really looking at the CPMH website. We've got a lot of resources. So that's Chartered Physios in Mental Health website. There's lots of resources and interesting information on study days as well there. And again, I'm on Twitter and quite relatively active on Twitter at Laura Hemmings PT. So please, kind of, if you're interested in the survey that I mentioned earlier, that's accessible there. And just for kind of general chatter and advice around mental health physio, please do contact me through there.
Superb. And UK?
Yeah, I echo about the CPMH website. I think it's a really helpful kind of pool of resources.
What's that URL, sorry?
CPMH, so Chartered Physiotherapist in Mental Health Care.
Is that .co.uk, .org.uk? Sorry to put you on the spot.
.org.uk. I'm looking to Laura there to maybe correct me. We could maybe share it on the chat if that would be helpful.
I'm going to do that. That's what I was going to do. I'm trying to be clever and do it on the fly, but let's make sure we get the right one. Sorry, you carry on, Kate. I'll find out.
Absolutely. And a little subgroup and tab within that CPMH website is our Chartered Physios in Eating Disorder Network group as well, which links references that would be relevant to physios in mental health, but also other physios in other areas that are interested in mental health. So
this is funny. This is why we always have to check the URLs because the cpmh.org.uk is the Charlotte Pratt Memorial Hall in Winkfield, Bracknell. So feel free, anyone that's interested, to visit that website, which I'm sure is pleasant, but not the one that we're meaning to signpost. So I will get that. I'll get that URL put on the chat, and obviously be sharing that on social media, because this has been such a fascinating chat. I think Laura's lost our audio, and so Laura, do you want to finish with sign language? I don't think she can hear us. So we'll wrap up without Laura. But thank you so much for your time, Kate. And I'll definitely be in touch and signposting people to this, as well as other work that you guys do, including then raising awareness of how people can get involved in the special interest group. So thank you so much for your time.
Thank you.
International Sign Language for bye. See you later, Laura. Take care. Bye-bye.